Hayley, thank you so much for sharing your powerful expression of your pain journey. And I do want to make a quick comment from one of our persons with lived experience who would like to share something that they wanted to comment for you. This person wrote, on behalf of all people living with pain, we'd like to thank Hayley for her candor and transparency at being human and sharing her story. You are so brave, Hayley, and your efforts to share and be so vulnerable is changing our community. Thank you.
Thank you. That's lovely.
Wonderful. Well, ladies, this is my, again, pleasure to be able to bring you all together, and let's talk about culture and communication. So if you could turn your videos on and also your mics on, that would be great. Thank you so much. So if you can tell, over the last few days, we've had many different themes that have been brought up for these three presentations today by each one of you. And I'd like to start with a reference that Dr. Tasha Stanton made this morning. She talked about our words matter, and she spoke about it in the context of danger and safety cues. So I'd like to open up this question and answer period to all of you. And I'd like to start with you, Hayley. How have words mattered for you?
It's really interesting, actually. I listened to Dr. Stanton's presentation, and there was a comment about, how many patients have heard you have the body of an 80-year-old. I actually early on was told I have the body of a 90-year-old. And so, to be perfectly honest, it didn't necessarily affect me positively or negatively, but the compounding of a decade of it, I've heard you should be in textbooks. I've heard we should study you. You're utterly unique, which I am unique, but I don't think it was meant in the flattering context. I don't know how to combat words like that, but the ones that I respected the most over the past decade were the ones if people were most honest. I wish I could help you, but I can't. It was disheartening to hear, but those words have always stuck with me as the most poignant, outside of some comments probably that were negative messaging. And her talk made me rethink my whole pain journey.
Thank you. And I'll go to Julia in alphabetical order. How do words matter for you when you're working with patients, or even as a person who might be interacting with another healthcare provider?
Words are very, very powerful. And in my context, because I'm working mainly and predominantly with individuals who are coming from different cultures, I always have to weigh my words. What do I say? How do they come across? How are they getting translated? Are they translatable? What type of echo are they creating on the recipient's end? So I have been always very, very mindful in how I select my words. I always wanted to diminish the power differential between a service provider and a service recipient, because I believe that at the end of the day, we are all people who want to be cared for, want to be heard. And we service providers, we want to provide a good service that is uplifting, that is helpful, that is empowering for our patients and the service recipients. So I definitely pay attention to my words. And being a multilingual individual, I speak Hungarian, Romanian, English, and French. I don't speak English as a native speaker. I think of my words, how do they come across, what do I say, and I weigh them. So yes, words are very, very important. Their content is important, how they are conveyed, the body language, the nonverbals, everything creates a unique messaging.
Wonderful. And I'm just going to add, I remember Dr. Tange speaking about degenerative disc disease and being able to reframe those types of words. So I'm just wondering, again, not saying that you have to lead with that, Lissanthea, but again, how do words matter for you in the context of narrative medicine or narrative discussions?
Right. Well, I think Tasha's brilliant work and bringing the idea of, placebo and nocebo words into the conversation. And I think it even comes back down to our sort of our Hippocratic oath, our idea of doing no harm. And the fact that words matter because the way that we interpret the world is narrative. The way that we tell our history, we tell our story, we share what we know of the world with this language and linguistic structure. So the words that I tell someone, or that Hayley's health providers have told her, go into her cognition, go into the way that she thinks, or someone else that someone that I work with. So it's a choice. And so it's a responsibility about having encountered those words or those situations in enough, safe ways to have more of a vocabulary, have a way to make even a difficult diagnosis, the need for honesty, the need for candor, the need to communicate authentically still can be done in a way that engenders hope, compassion. I think that's what our most skilled clinicians are really able to do, is to use words to keep that hope alive, even in times that might be quite dark. So words, 100% I'm with Tash on that, and with so many other people, that words really do matter.
Thank you, ladies. And building on that, sometimes our words unintentionally come out in a way that might be misinterpreted. I know I've had to practice, I've had to ask for feedback myself, and just ask someone I'm working with, how did you receive that? Inviting them. And I think we've talked about that. You spoke about that. I think throughout your presentations, Lissanthea, and also Hayley, I did hear that as well too in your presentation. So I'm just wondering, when we want to practice, when we want to invite the other person we're working with, whether it be from a perspective of team to team member, or person with lived experience and clinician, how can we do that in a way that is building and engaging, and actually, Hayley, as you said, to be understood and heard? So I'm going to start with you again.
I really do think that hearing my perspective would probably be the best way to start that, because if I don't clearly state, most people who know me really well don't know what I just presented. And it's because part of it is it's hard for me to face it, but the other reason is it's very, very hard to relate to. So I think that would be the key when communicating with a care practitioner, is somehow using my words in order to start eliciting maybe different responses from the practitioner, instead of just keeping it at a surface level of, yes, I live with pain.
It sounds to me like you want us, and not us and you, but it's for us to get deeper and go a little bit more into that and using your words. Absolutely. Thank you so much. Lissanthea, do you have anything to add or?
Yeah, I think what Hayley's asking us and should be asking us, and all of the people that come to us for care are asking, to be included, for this to be a shared space. We might call it a third space, an intersubjective space that is allowing us to create something new in that space that is shared, that enables Hayley's voice and my voice, or a care provider's voice, kind of to bubble up and to make something that really works for that person that's come for care. And that's, our systems within healthcare are not set up for that. They're very hard to, it's hard to have that space and that communication when you might have 15 minutes and as a clinician, you missed out on lunch, or you shoved a sandwich in sitting at your desk trying to write notes. So many things, and I think maybe this is a bigger social commentary, that many things get put onto individuals that are system level, and I don't know how to solve that problem, but we also perhaps would be useful if we're thinking at how do we structure clinician time schedules? How do we look at payment? How do we help all of the stakeholders to benefit from a shared conversation? How do we make it a space that works?
Wonderful. I don't know if you knew this, but we had that exact same question that was posed to you regarding how can we use narrative perspectives in a short time period when folks need to speak with their physician for 10 minutes or 15 minutes. So that was a perfect segue. And so I'm going to invite all of you to comment on that from your experiences. So allow whoever wants to go first, please go ahead. Go for it, Lissanthea.
Well, I'll jump straight in I kind of come back to the slide that I put up with Daniel Kahneman's Thinking Fast and Slow. That and we've talked about this within sort of narrative medicine, and we often get the pushback of, well, I don't have the time, I can't close read a patient's story. But if you practice in that safe space, and this is a little bit like, and again, I use my football analogy, that you practice enough, a skilled soccer player can, sees the gap, sets up the goal, works with the team in a split second. And when you develop these skills, and thinking in sort of cognitively, it becomes a sixth sense. It becomes something where you can see, this is not right. I'm missing something here. How do we get quickly to the heart of what's going on here? So, the time spent is the time building the skill outside of the clinical interaction, but it's a buffer to enable you to do that. Now, there's a time commitment, there's a willingness, there's an openness to doing that, and it's not infallible. No skills are, but that's how I push back on I don't have time for listening to stories. I'd say get better at stories, and they take less time.
And so, Hayley, thank you so much, Lissanthea. What's worked well when you've had those brief interactions with any of your team members? What have you liked to see that's helped you to be understood and heard?
I'm actually part of a pilot project currently on shaping neuroplasticity, and the last session was fascinating to me because I think you could probably understand me and others in there within a very, very short amount of time. And it came down to our definitions of 2 words of activity and exercise, and one about strength. And essentially for the people facilitating, they hit this aha moment of, oh, so you might resent everything that we have suggested, but you have activities and exercises and what have you that you like, and you drive your strength not physically, but internally. And then all of a sudden, they understood us on a whole new level. Everything's progressing. It's taken more than 10 years for me to have that experience with a practitioner, but those moments, or the ones where I am as open and raw, it doesn't have to be lengthy. Those are the ones that I remember.
Thank you for sharing that. And building on time, Julia, you spoke about how when we're working with folks who might have a different language as their first language, that to allocate appropriate amount of time. So what's worked well for you in working at the Refugee Health Clinic?
Before I answer your second question, I wanted to add something for the previous question.
Sure,
I thank you. I do acknowledge that we work in a highly structured healthcare setting where we don't have the time, or so we say. But I believe that there is an underlying issue as well. How do we present ourselves? What do we bring into the session? Am I bringing only my cognitive empathy? I understand what you say. I understand your pain. Or am I bringing my affective empathy as well? Because if I'm bringing my affective empathy empathy, then I catch the story. I catch the micro expressions. I catch the body language. I catch their breathing, and I would be able to understand them way better, even if the time frame is shorter. So the question for the provider, what are you going in with? Are you going in fully armed and fully guarded to protect yourself from burnout? Or are you going in with your humaneness, with your vulnerability? And for me, this had worked. I don't only take my brain to work, I take my heart to work, and I take my body to work. So this for me was absolutely the key of being able to connect in a short time or in a briefer time. And now to answer the second question, I have a little bit of a luxury compared to other service providers because I have 60-minute sessions. So in 60 minutes with 11 years of experience, I managed to structure my thinking. And I presented in my presentation that I am able to make the linear assessment into a multi-active assessment, a linear assessment that doesn't sound like an inquisition. It sounds like a conversation where stories are being told, and I am picking the fruits and the cherries from the story and inserting them into my very linear assessment. Because the assessment is linear in my mind, I just convey it in a very conversational way.
And I'm sorry, I was realizing I was on mute. Thank you so much. Absolutely. This is free flowing. And I know I'd like to keep the conversation going for a few more minutes here because this is very, very insightful. And I hope this appeals to many people. We talked about also the role of being able to be diverse with our approaches. And we have a question for you, Julia, actually regarding the Lewis model. So is there plans to diversify the Lewis model in the future, and what is the plan for that? Might you have any insights on that?
Unfortunately, I do not. I contacted them for copyright and for use of their images and content, but I do not know whether they will diversify it or not. And I am a little bit sad that this was a virtual platform because I am as you can tell, I'm a talkative person. I like to connect with people and I like to receive the questions as we go. I appreciate the model because it definitely accounts for the reactive type, so the yellow corner. In previous cross-cultural models, that yellow corner was completely missed. It was completely non-accounted for. So the Lewis model brought this brilliance into incorporating that cultural presentation into existing models. And as I said, that is the area where I have the least expertise. And I feel that I am still on foreign territory when I am faced with that cultural presentation. Unfortunately, I do not know if the model will be expanded. Richard Lewis is quite old. He's very close to being 90 years old. So I'm not sure if somebody took the torch and is continuing his work.
For sure. And there's a second follow-up question that any of you can also address. And it's specifically regarding for patients that may believe that pain and suffering is a punishment. How do we provide support and coping strategies to those folks? And I'll open that up to Julia, Lissanthea, and also if you have your own perspective too, Hayley.
I'll take it to start with, Christelle, and I think it all comes back down to hearing what is the basis of that. Well, does someone want to share what might be the basis of that story, and what does that mean to them? And I think not judging if like people do, and I think this is where perhaps pain education, which I use as a very broad term for lots of things that we do in the clinic, and perhaps even our education is about, we are empowered to tell people how things are. And if someone's belief and belief structure is based upon that, we have absolutely no right to question that. We can talk about whether it's helpful and does it stop someone doing something, and does it get in the way of things they value and they care about and things that matter to them and who they are as a person. I think if someone's willing to engage with those conversations, they're conversations we can have. They might also have to coexist with those same beliefs about punishment. So it's that tricky holding two positions and that uncertainty that we don't like as clinicians, but we can build our ability to manage in that.
Thank you. Julie, do you have any insight in that as well too, from your experiences?
I actually do. I have a bachelor degree in theology, and I have heard comments like this before, like quite frequently, that this is God's will in my life, this is punishment because of this and that and that. And I usually entertain those conversations if the service recipient is open to having the conversations. And oftentimes I'm finding that there is guilt associated in their life with something else, a perceived things that they have done, or they didn't do enough, or didn't do well enough. So I have had the opportunity of working with individuals who perceived something as a punishment in their life, and we were able to unpack it, and we were able to look for evidence in their life, like, is this perceived, is this tangible, can this be proven in your life? And definitely I will go with what they say, because it's their perception, it's their worldview, it has meaning in their life. But if they allow me, I would definitely accompany them in unpacking some of that thinking. Where is it coming from? In a very safe way, in their own pace, in their own rhythm.
Wonderful. Hayley, do you have anything to add to that?
Well, for both Julia and Lissanthea, I would be interested to know if some of those people actually thought of that rationale and that reasoning of it as support for them to understand why it's happening to them. I personally am not of any faith, and so I've never gone down that road, but I definitely early on, when I was struggling with what the hell am I supposed to do with this, it was, why is this happening? But as I said, it's been so long, you can't dwell on it. And so I, perhaps not phrasing it correctly, compartmentalize it enough to make it very objective when I do go to practitioners, unless it is a counselor or something like that.
And do you have anything to add, just how Hayley kind of interacted with the two of you?
I think I would... I think trying to answer your question, Hayley, is it helpful or unhelpful? And letting someone self-determine that. I mean, if the belief is helpful and it serves them, and this is a more general comment, perhaps not about religious belief or whatever, if it serves someone and perhaps it gives them, for someone maybe that doesn't have a diagnosis. I mean, diagnosis can be such an important thing to be able to answer that question of why, and if it's something, if it allows someone to hang their hat, on something and give it meaning, and that's in perhaps, an unmoored experience, to provide that, if that story provides some stability. Remember, stories evolve, stories change. That might be the story for now. That might be the story that needs to be the stepping stone to the next one. So if it's helpful, it's helpful. And we have to allow someone to have that as helpful. And it's their time to decide when it's not helpful anymore, based on maybe encountering some new information or changing something else in their life, or it might stay helpful. But giving them the choice and the opportunity. I hope that sounds okay to you, Hayley. How would that feel for you as a way of approaching experiences?
It would add a level of empathy that maybe you don't get in a short time frame, a 15-minute session versus 60 minutes. For me, again, because I never had that lens, I kind of always want something to work towards, which is why I seek different treatments now. And that is just how I direct it, but I do think I have the luxury, if you can call it that, of 10 years of this. So I've really been able to explore it. It might be a little tougher right in the beginning at very short doctor's appointments.
Wonderful. Anything to add, Julia, to that? That was actually a wonderful experience to see that in action. So thank you for digging deep, ladies. But Julia, anything else to add to enrich the conversation that's happening right now?
Not at this point. Thank you.
Wonderful. Well, I'm cognizant of time. However, I just know that I'd still like to keep the conversation going. So I'm going to ask one more question of the group, and then we're going to move towards having some nice closing remarks from our president, Dr. Tange. But again, I just want to thank each one of you. And I want to reflect on something that Lissanthea, you said, and I hope this relates to all of you. You said giving each other or giving the permission and the approach for self-care as a whole person fulfillment. And I think that whole person and attending to our needs from many different aspects, our culture, how do we identify? How do we need to be heard? How do we need to be understood? And that could be through our feelings and through our stories. So I'm just wondering if you have any final thoughts just for knowing that our attendees here might be people with lived experience. They might be caregivers or family members, or they might be healthcare providers. How can we give each other permission to fulfill that whole person approach when we're speaking with each other? And I would like to start with you, Hayley, if that would be okay.
Sure. Yes. Honestly, when you were saying that, the first thing that came to mind was how I have had to learn that every care practitioner I've met with has their own perspective and wholeness. And I've learned over the years to actually not go in with expectations of anything other than this is what their specialty is. Maybe we can work towards something different, and to actually fully understand that they are there to help me in the best way they can. And I'm there to do the best that I can to let that happen. So I do think it's a joint thing, and people with pain, just hang in there with it and try and work with these practitioners because they want to help you.
Thank you so much. Let's change it up and go to Julia.
So again, as I mentioned earlier, I believe it's very, very important for me as a service provider to bring myself wholly into the session with the care recipient, and to be very, very mindful that I am neither the expert of their pain nor the solution to the pain. I am a helper in the process, and to consider the individual as a whole person, not a diagnosis, not their pain, but as Hayley said, she's much more. She's a complete human being with wishes and dreams and ambitions, and pain is part of her life. So seeing that this individual comes in for a particular issue, however, they're way larger than that, and bringing my emotional availability to the session is very, very important for me. As I indicated, I'm coming from a culture that is very, very emotionally expressive, very relational. So I cannot imagine interaction where I am only bringing my brain and not bringing my heart. So bringing myself wholly and allow the service recipient to be themselves wholly, whether they feel like crying or swearing or cutting the appointment in half because they can't tolerate it anymore. It is them, and I have to be able to contain that.
Thank you, Julia. And I'd love to hear your thought. We all would love to hear your thoughts too, Lissanthea.
Well, I just want to thank you, Julia, for the reminder of bringing, of the embodiment. And, and I think when because we talk so much in pain about neuroscience and about the brain, but we're not, the jelly in a lunchbox just up here that's, running the show. We have this knowing, this knowledge, this intelligence in our whole self and our whole being, and our interactions with other people, can keep us whole. So I would end with, I would say this maybe to our health practitioners in service of people that come to them for help is an ethic. Is a strong ethic of self-care, of self-compassion, and of taking a really firm stance when Julia was talking about being able to be vulnerable and to bring your whole self, if you haven't got that, you can't give it, or you're digging out of sort of, and you're borrowing from your capacity to give to your family, to give to your friends, to be able to do those activities that are going to keep you full and able to have that, mental and physical space to interact with people in a way that acknowledges their whole self. Well, you can't do that unless you are in your wholeness also. So this is about, well, how do we really, perhaps take a bit of a firmer stance against overcommitment, about scheduling, about all of these things that might seem like luxuries to take a lunch break. How do we actually develop perhaps a bit stronger boundaries? Because with boundaries, we're able to give more.
Wonderful. Thank you. Anything else to add, Hayley? Because again, your voice has been really powerful, and I know we would love to hear anything else that you wanted to add.
Honestly, I could probably talk about what I've studied culturally. I've done some of the things Julia talked about. I could talk to Lissanthea probably for days. And same with you, Christelle. As you know, it's a very subjective, personal thing, pain, and the practitioners that deal with us, same goes. It's been an evolution for me. This today, thank you for the opportunity, has been the next step in that evolution for me. And if not much good other than being able to maybe be a voice for others dealing with pain and earlier in their journey is what comes out of this for me, then that's great. I'm happy and honored to do that for you.
Thank you so much. That is a perfect way to end. And I thank each and one of you, ladies. And I see in waiting, Dr. Tanguay and Rob joining us, who will close our conference for the day. So again, thank you, ladies, for joining us.